Arthroscopic ACL avulsion fixation with knotless suture anchor, a minimalist approach. The authors have nothing to declare.
This is the schematic demonstration of our proposed technique. Standard diagnostic knee arthroscopy was performed using the AL and AM portals. After identifying the avulsion fracture, debridement was performed to remove any interposed fibrous tissue. The avulsed fragment were then identified and probed to assess its reducibility. Next, a suture hook preloaded with a PDS suture was introduced through the AM portal and positioned just above the ACL insertion. The suture hook will maneuver to penetrate the medial side of AM fibers and exiting from the anterior 2/3 of the PL fibers. A double-stranded epibone was shuttled into place by pulling both ends of the shuttle suture externally through the AM portal. A loop was created outside the joint. One end of the suture was then fed through back into the joint to form a loop encircling the ACL substance. The anterior tibial slope bone area located just beneath the transverse meniscal ligament and approximately 0.5 to 0.8 centimeters anterior to the ACL insertion were identified and then tapped along the longitudinal axis of the ACL, and the fibular knotless suture preloaded with the double-stranded suture were placed in tap hole and secured while maintaining the knee at 90 degrees of flexion. The suture tension was adjusted to achieve optimal reduction of the avulsed fragment, and finally the reduction was evaluated using a probe, moving the knee from a range of motion from flexion to extension. In conclusion, this technical note presents a minimalistic arthroscopic approach for fixing ACL avulsion fractures using a knotless suture anchor. The key advantages of this technique include its simplicity, reduced risk of iatrogenic injury, adjustable tension, and suitability for younger patients with open physis. By eliminating the need for additional incisions, bone tunnels, or complex intra-articular knot typing, this method offers a promising alternative to traditional fixation techniques, particularly for Meyer's and McKeever's type 2 and 3 fractures. However, further biomechanical studies and large clinical trials are necessary to validate the long-term efficacy and safety of this approach compared to existing methods. Nonetheless, this minimally invasive technique has the potential to simplify the surgical management of ACL avulsion fractures and improve patient outcomes, making it a valuable addition to the orthopedic surgeon's armamentarium.